is, are children and adolescents less likely to respond to mood stabilizers than adults, or is it a matter of which patients were included in these studies? We don't know. Even lithium in the one study by Bob Kovac, which has not been published yet, also did not separate from placebo. Same is true for response rates, which is similarly rated as in adults a 50% or greater reduction in the Young Mania Rating Scale for mania. And you can see here that only the one arm where valproic acid given as immediate release formulation separated from placebo rates. Similarly to antidepressants, the FDA pooled data from placebo-controlled trials for suicidality with mood stabilizers, both in patient groups with epilepsy and those with psychiatric disorders, finding again that there seems to be a signal for increased suicidal thoughts and behaviors. Actually, the actual event rate was somewhat higher in patients with epilepsy. The relative risk was higher in patients with epilepsy compared to patients with psychiatric disorders, but the risk difference per 1,000 patients was higher in psychiatric patients, 3.1 patient events per 1,000 exposures versus 2.5 with epilepsy. So something again where we need to monitor patients. Question here is, do again those patients get more mood stabilizers who are behavioral disinhibited from the beginning, and how compliant are those patients? That is another thing that is not always measured. Looking at the antidepressant literature in Scandinavia, actually many autopsies showed that patients that were considered to have killed themselves while they were taking antidepressants actually did not have any antidepressant level. So again, the direct association between the medication and the event is somewhat unclear. What are other side effects? Well, mood stabilizers, whether it's lithium or divalproex, can cause weight increase. They can cause some neurologic side effects if they are dosed too high, and also can give some sedation. Here you see it with lithium in this study by Mani Pavuluri. There's another side effect that can occur with lithium. This is the study by Barbara Gracious, where she showed that basically TSH, thyroid stimulating hormone levels, were much higher in those patients treated with lithium, again showing a tendency, like in adults, that patients can get hypothyroid. Who was at higher risk? Those that had already higher levels of TSH to begin with, and those that received higher dosages or greater milliequivalents per liter of lithium. What about valproic acid and divalproex? Here again, a study by Mani Pavuluri showing that about 60% of patients experienced some weight gain, and also about 50% almost experienced sedation, which can be lingering. Many of our studies, unfortunately, don't measure how long sedation lasts, and that's relevant because our patients need to go to school, need to attend classes, and be socially active. So sedation during the time where a lot of building up of educational experience and social experience occurs can be particularly detrimental. In addition, divalproex has another effect that has not been studied in children yet, in females, but this is the data here on this slide, where females that were 18 to 45 years of age, 230 women were studied naturalistically, either receiving divalproex or another anti-epileptic or lithium. No antipsychotics were given, and the rate of polycystic ovary-like syndrome or symptoms was calculated, and what you can see here is that the rate was 7.5 times higher in those patients receiving divalproex compared to other medications. 10.5%, 1 out of 10 women had symptoms that were consistent with hyperandrogenism, including oligo or amenorrhea, less than 9 menstrual cycles per year, hirsutism, acne, male pattern alopecia, or elevated male sex hormones. and that is obviously of concern, whereas only 1.4% of patients who were given lithium or other anti-epileptics had that. So it's not everybody who receives valproex, but clearly 1 out of 10 patients has that risk, and if females of childbearing age can be treated with other agents, that may sometimes be more preferable, and clearly these symptoms need to be monitored. Let's shift gears now to antipsychotics. And on this slide you can see an increase in the antipsychotic use since 1994 to 2004, which has been quite dramatic in terms of outpatient contacts. Antipsychotics, particularly atypical antipsychotics, are now used not only for psychotic disorders or schizophrenia. Since the early 2000s, the adult data have shown, and since then also pediatric data, that atypical antipsychotics are very good mood stabilizers for mania and mania prevention. And there are data to suggest that antipsychotics are also very good for aggression and agitation control, and those two symptom clusters are very commonly associated with admissions to child psychiatric units and also with antipsychotic use. On this slide I mapped out the response rates as defined by the study for autistic children and adolescents. Most of the studies that were larger have been conducted with risperidone, which also achieved indication for autism in 2007, I believe. And here you can see that all response rates are pretty high and much higher than with placebo, with the number needed to treat between 2 and 7. There have been some small studies with olanzapine in pink here, and some recent studies that are currently under FDA review with aripiprazole, where again either fixed dose of 5, 10 or 15 milligrams or a flexibly dosed study compared to placebo showed significant superiority in the aggression rating for autism. Antipsychotics do not seem to really alter the disease in terms of psychosocial relatedness, but clearly the aggressive behavior is very well treated with a low number needed to treat. Similarly, risperidone has been tried in disruptive behavior disorders, either against placebo or in one study against haloperidol, here in blue. Again, very strong effect sizes with a number needed to treat of only 2 to 5 for disruptive behavior disordered youngsters. Moving on to pediatric bipolar disorder, which has been discussed rather controversially in the literature, particularly in the public domain, where the concern is that maybe bipolar disorder could be overdiagnosed for patients who have mood swings or emotional outbreaks. But many of us treat patients not based on diagnoses, but based on the symptomatology that is severe or disturbing enough for patients to actually come to attention of a psychiatrist or child psychiatrist. So here, looking at patients that were actually diagnosed with bipolar I disorder, you can see that for all atypical antipsychotics that have been studied, starting from the left, olanzapine, then aripiprazole, risperidone, quetiapine, and ziprasidone, all arms that have been studied, either flexibly or fixed dose studies, have shown significant superiority against placebo in gray. And you can see that roughly, although these may be different patient populations, the effect, the reduction on the Young Mania Rating Scale score was similar. Moving on to the next slide, we can now see response rates, which are uniformly defined as a 50% reduction in the Young Mania Rating Scale score. And here you can see again that roughly similar response rates across atypical antipsychotics on this slide, and always significantly superior to the placebo response rates. These studies lasted between 3 and 4 weeks. We do not have a published placebo-controlled maintenance study, but there has been one that was completed with aripiprazole for actually another 26 weeks after the 4-week initial treatment, showing again a maintenance of the efficacy that was achieved at the end of 4 weeks in those patients that were continued for up to 30 weeks. Moving on to schizophrenia, which has been the usual domain for antipsychotics, we can see similarly that all atypical antipsychotics that have been studied separate nicely from placebo. There have been some older studies with haloperidol and loxetine But these were very small-scale studies and not powered enough to really show good separation from placebo. On this slide you see our, again from left to right, olanzapine, then 2 doses of aripiprazole, then risperidone. The 4th trial is actually a risperidone trial against pseudo-placebo, where patients got 0.15 to 0.6